Welcome everyone to the December CDPC quarterly meeting. I want to welcome you here. My name is Laurel McCloskey. I'm the Executive Director of the Chronic Disease Prevention Council. And the purpose of the council is to be a coordinating body to address chronic disease prevention statewide in New Mexico. And this is done by three areas that we've really focused on over the years: advocating for prevention policies and programs, facilitating collaboration among agencies and organizations working to prevent and/or manage chronic disease, and lastly, supporting initiatives to understand, identify, and address social determinants that impact chronic disease. A big part of our work is the iteration and the implementation of the New Mexico Shared Strategic Plan for Prevention and Control of Chronic Disease. We're currently working on revising the third version of the plan for the next 5 years, so it's pretty exciting. It will be a 15-year project. And the plan looks at empowering New Mexicans to make changes that create healthier communities by looking upstream at preventions, policies, education, working within our communities to reduce chronic disease. And a major shift in this plan over the years has been looking at the whole system approach by focusing on risk factors that impact multiple diseases. So we can put a copy of that plan in the chat to spark your interest. A lot of times at these meetings, we touch into priorities of that plan, but as it's under revision, we're going to hold off today and just have a regular quarter meeting with 2 presentations. And John, is there anything you'd like to say?
No, Laurel, thanks for asking. I'll share a little bit more about the plan when we have our breakout conversation at that point.
Well, without further ado, we put the agenda in the chat. We have our first presentation. I'm going to do a quick bio for Sheryl, who's joining us today with her presentation. And following her presentation, we'll have a quick breakout session where we'll look at the plan, address some questions, and dive in deeper. It's a way for us to connect in this virtual setting. And Sheryl Wilkeson, she comes with us from the New Mexico Heart Association, American Heart Association. She's their Community Impact Director. And she's really focused on making a difference in the health and lives of people in our community. She really looks at how we can build powerful partnerships, speak with a trustworthy voice, bring science to life, and meet people where they're at. She has been here only recently in New Mexico, but before that, she was working for the Western States affiliates. She has worked with the United Way of San Diego County, the American Indian Service and Engineering Society, and she holds her Master's of Public Administration from the University of New Mexico. And I welcome you, Sheryl. She's also the chair of our Heart Disease and Stroke Work Group. She dove into that position recently as she's in New Mexico and has been doing great things. They did a series of community impact assessments that will be really exciting to come, looking at projects from there. So we're really grateful to have her here today. If you have any questions for her, just some housekeeping, put them in the chat. We'll be sure to address them during the breakout sessions after her presentation, and in the chat's agenda if you just want to follow along with timing. And without further ado, Sheryl, I hope I didn't miss anything in your bio.
No, you did great. I'm going to share my screen. Are you seeing it?
We are.
Yes.
See your slide.
Okay,
yes.
Very good. Oh, very good. Thank you. Let me go back to, oops, pardon me, real quick. Sorry, let me move this over. There we go. All right. So, well, I am pleased and pleasure. It's a great pleasure to be here today to present to you. As Laurel says, I'm kind of new, and boy, you guys just throw people in, so I'm excited. So hopefully I will be able to share some enlightening information and kind of spark some conversation and opportunity and space for collaboration as we go through. So I think everybody learned who I'm with. So American Heart Association, my role as Community Impact Director is really putting the mission to work in our community. So my goal for today is just kind of talk a little bit about the work that we're doing, and I create a space for feedback and really look at some of the work that we're doing. So While AHA continues our advocacy and research efforts, the AHA really recognizes that transformational change at the local level is fundamental in achieving our mission. So as we go through, I would hope, I know we have a breakout session at the end of it, but feel free to pop things into the chat or come off mute if that's allowed to do that, because I don't even want to hear myself talk for 15 minutes. So I'd love to, I know there's lots of experts of what I'm going to talk about in this as part of this group. So I'm looking forward to an interesting conversation. So where we work. A lot of people may not be familiar with the total scope of the work that American Heart Association, definitely for groundbreaking cardiovascular research and best practices with the medical community, is just a tip of the iceberg. So this is just kind of a roadmap to the work that we're doing in the community. So we work with the government and the public with policy and advocacy. We work in the schools with kids and educating them on vaping and tobacco. We work out in the community teaching about prevention. And we work with corporations in creating health equity in the workplace and addressing healthy workforces. We really work at improving care and response and providing patient education and support. So all of this kind of comes together that plays an important part of that. The work that we do, we talk about building a culture of health in the community. And we know that it's more than just, you just can't tell people to eat better or exercise more. That may not significantly improve behaviors over time because we've not taken in individuals' environments and the resources that they have. We have to think about, when we talk about the health of the person, we have to talk about their resources. Access to resources, neighborhoods, environments, and what they have to support any decisions that they have to make themselves become more healthy. For example, we have to take into consideration what is the percentage of people who work in places with clean air or smoke-free air? What is the percentage of underserved people who live where affordable, healthy food options are scarce? We know these are very complex issues that go deep into the infrastructure of a community. And we know that the only way we're going to address these is if we work to engage community partners and collaborate to address the issues that are impacting the community's health. Following are some of the ways that we are working to toward a healthier community, and it's also an open invite for anybody who would love to collaborate and work with us as we move forward. These are kind of some more things about so overall, the mission statement of American Heart Association is to be a relentless force for a world of longer health. Longer, healthier lives. We are guided by our values and we have a strategic value proposition. Our mission makes it clear, but there's a lot more to it. Everything that we do is grounded in our values. We talk about meeting people where they're at and creating powerful partnerships and bringing science to life so that everybody understands. There we go. Our strategic shift has been fueled by everything that we do. It's all been brought about by the evolution of science. So we started out, in 1924, just being a public reminder or provider of education, went into acute care, risk factors. Really, in 2015, we started to do a shift. But really what made the strategic shift was what created a change for everybody. I mean, COVID-19 really changed how most organizations work and see their work. Not only did COVID-19, but also the social justice actions accelerated and underscored the need to address health inequity. The focused effort is a natural extension of our nearly 100 years of saving and improving lives through science. We went from awareness and treatment to prevention to social determinants of health. We've made tremendous progress over the years, and now we fully understand just how deeply social determinants of health are rooted in structural racism. By 2015, we found that gains were made, but not for everyone. People of color and communities without resources were disproportionately impacted by heart disease and stroke. We had to figure out why. And again, science pointed us in the right direction. And we began to focus on social determinants of health, like access to food, access to healthy food, affordable housing, and good jobs, clean air, and education. But even the combination of all of this work wasn't enough to address the health challenges facing all the populations. So science again led us to additional area of focus, which is structural racism, and which is the driver of health disparities. To reach our goal for giving everyone the opportunity for a full, healthy life, we must remove these barriers to health, including structural racism. So this led us to our 2024 impact goal. At American Heart Association, we usually create impact goals for every 10 years. So when 2020 come around, we're right in the middle of COVID-19. We were getting ready to launch the 2030, but that's when the data started to come out showing a bright light of how disproportionately COVID-19 was impacting certain communities. And so what American Heart Association is created our 2024 impact goal, which was really wanted it to be more urgent, more responsive to what's going on today, so that we would make direct, instead of having 10 years to work on this, we didn't feel we had the time. We really felt that we needed to get this done within 3 to 4 years. So we created our 2024 impact goal. And through that, we say that everyone deserves an optimal and just opportunity to be healthy, given special attention to the needs of those at the greatest risk of poor health. No one should be disadvantaged from achieving their potential because of social positions or any other socially defined circumstance. Let's see. So we started looking at if we're working towards health equity and we need to address the barriers to health equity, what are those health equities? So I don't feel that I need to really kind of break this down, but of course, number one, social determinants of health. That is something that we all work on to address. Work on to address oops, I'm going to stop for a second. Are you guys still hearing and seeing me?
Yes.
Yes, we can see you and hear you.
Okay, I'm getting unstable. Okay, thank you. And unstable internet connection. So if I have to, I'll go off camera, but hopefully it will continue. So social determinants of health. So, I mean, I was wondering, I know I'm speaking to the choir here with a lot of people. So who can tell me what they think, what is a good definition of social determinants of health? You can not have me talking all the time. Anybody? All right, well, I'll just continue through. So of course, social determinants of health are the conditions in which we are born and live in. They're not due to any, fault or, consideration of the people that it is impacting. So, oh, very good. Somebody, So that's really great. So good. Thank you. And then, so that's the social determinants of health. The next is structural racism. So at American Heart Association, we, along with lots of other organizations, have come forward and officially stated structural racism as a health crisis in our country. So that's really important for us to really look at. We also have, I was going to ask about anything, but structural racism is a system in which the public policies, the institutional practices and cultural representations and other norms work in various, often reinforcing ways to perpetuate racial group inequity. And then the third barrier that we work to address that is really important, especially here in New Mexico, is rural health disparities. So rural health disparities is really important here in New Mexico because rural health communities face unique health challenges, including higher individual risk factors for chronic disease, social influences that impact health, such as lack of access to quality education, fewer economic opportunities, and the challenge of not having affordable healthcare services regionally and in the community. So these are the three barriers that American Heart Association is really looking at addressing. Oh, yeah. What I wanted to do is kind of bring it to life for everybody. So we wanted, so what I did is kind of take a deep this is a made up person, but it wanted to kind of share do a deep dive into it. So we know that structural racism is the cause of poor health and premature death in heart disease and in stroke in communities of color. So that's the big picture. So what does that look like for an individual? So this is Michelle, and Michelle, in Michelle's life, this is like 2019, things were going pretty well. She had a great job, a close family, a network of friends. At 53, she generally felt healthy, and all in all, life was good. But when the pandemic hit, Michelle worried about her being laid off. Her stress level went through the roof, and especially when her boss called and confirmed her worst fears. Her 20-an-hour job was gone. Weeks went by, bills piled up, and so did the stress. One day during her job search, Michelle got a bad headache. Her children worried and persuaded her to go to the hospital. There, Michelle was stunned by the news. She had a mini stroke and was diagnosed with high blood pressure. Thankfully, she was okay, but needed to make some changes in her life. The doctor gave her a prescription for 3 different medications, shared with her about the importance of eating healthier and getting more active. Michelle was committed to getting her health under control, but it didn't take long to hit her first barrier. She lost her health insurance when she lost her job. She didn't have a primary care doctor. At the pharmacy, she could only afford one of the medications, and she was starting to feel overwhelmed. But she could at least do the other things the doctor had recommended. Michelle stopped by the mini mart, but she couldn't find low sodium foods. For the first time, she realized there was very few fresh fruits and vegetables in her local store. She picked up a can of vegetables that she usually buys and read the label and put it back, seeing it had too much sodium. On the way home, she realized it was going to be tough going out to walk too. Cars were zooming by and there wouldn't be safe since there were no sidewalks. Following the doctor's order was going to be harder than she thought. Michelle's story isn't unique. There are countless others like her in her neighborhood, and there are other communities lacking access to the most basic needs to stay healthy. They lack supermarkets stocked with healthy foods at affordable prices, decent paying jobs, and education needed for them are both scarce. Neighborhoods like Michelle's have not been invested in for decades, and the lack of meaningful investments has resulted in systems of obstacles that are difficult to change. The neglect is so apparent that it actually shows up on maps. People within Michelle's zip codes have a lower life expectancy than a nearby community, 20 years lower than in some areas. Communities like this are a recipe for perpetual cycle of poor health. Stories like Michelle's are why the American Heart Association is championing health equity and why we're doing in such a way and so urgently. Michelle may only be a fictional illustration, but the problems are real. So what can we do? What we believe is that we can take the impossible and make it possible, and through community transformation. And transformation is about getting organizations to work together to orchestrate transformational change. With American Heart Association, transformative change is about what we call PSC work, policy, systems, and environmental change. So that's both capital P policy work and small p policy. We are looking to convene partnerships which will be guiding our work by science to maximize investments in building health equity and eliminate health disparities. We hope to foster collective action that improves quality of life and increases opportunities to ensure care for all. Our shared vision is that every member in our community will be able to have, to feel supported by the places that they work, play, live, and heal. The work that we do at American Heart Association, how we drive change, is through our partnerships. We are kind of at the crossroads of both clinics and community work. What this looks like is what we call it the peacock here at that. So this is our health impact or health equity peacock. Health equity is going to be, from moving forward, at the center of everything that we do. We look at the key priority areas, which is women, COVID-19 and community response, commercial tobacco and vaping, well-being, nutrition security, high blood pressure, and chronic disease. We are concentrated on these specific areas because it's where there's an urgent need to make a profound impact. Additionally, we still having our events and the opportunities, but we want more meaningful opportunities for partnerships, for the donors and the sponsors to get involved and make a difference in the areas that is most meaningful to them. As you look to see, one of the things that we look at, so you'll see at the wheel that equity is at the center of it. Access to care is at the top of our foundation. So these are some of the importance of what we look like, what it looks like out in the community, what we're working on internally, and how at the center of it is equity. And it's all built on the quality of care work that we're doing, the research, and how it's all being tied together. Let's see. Some of the work that we're doing and the reducing risk for women is we really want to address the risk that women are at. 1 in 3 women pay the price with their lives when it comes to cardiovascular disease. We often think of cardiovascular disease as a man's disease, but it's the #1 killer of all women. It affects more men, but it kills more women. So we really need to raise that awareness. Addressing COVID-19 is still going to be an important work that we're doing. 75% of all people hospitalized with COVID-19 had a high-risk condition. oftenly are negatively impacting our people with cardiovascular disease and stroke. Along the lines of addressing COVID-19 is our emergency response and CPR, which is an important part of where we come from and what we see in the future. So I am going to hopefully show a slide. Let me know if with the thumbs up if hopefully you'll be able to hear.
It's hard to go back to that. Chuck and I were at a meeting, and my phone kept going off, and that's when got the news from assistant principal that Charlie went to the hospital to get there.
It was just like any other day. I saw him between that crack over between the stands and the concession stand. And I came out on the other side. Charlie is like as if something really wrong with him. As I approached him, I could absolutely tell his phone was already, and he was motionless.
I just mentioned assessing him, and I immediately knew he did CPR and called for the AED, and we just couldn't stop.
Still hasn't settled that I had a cardiac arrest at 15 years old.
All right, I'm getting
Sure,
that
getting
the
confused.
audio
Yeah,
is choppy,
choppy.
so yep. Okay, so I'll give it. I'll send it up to you guys, and maybe you could put it up on the website or send it out. Okay, very good.
Sounds great.
So the main thing is, there you go. So the main thing is about this is that definitely, I mean, sudden cardiac arrest is the leading cause. Oops. Let me go to the next. There we go. So we'll do that. But the main topic of that is that cardiac arrest and emergency response to it is, and why that's important is that it does access to emergency response is also a health equity issue, both in communities of color as well as lower resource communities, as well as rural resources. So there are steps that American Heart Association is taking to address that as we move forward. So that's an important goal and vision, especially here in New Mexico, that as we move forward to it. So hopefully when it's up on the website, you can watch it because there's some important information on that and some good ideas about how we can move forward to address that here in the state of New Mexico. So the next one that is a key priority for American Heart Association is promoting mental well-being. Definitely, there's hardcore science about the connection between the brain and the heart. American Heart Association is a science-based organization, an evidence-based organization. We don't really jump on to any new fads or anything. So if we put something out there, we know that there's lots of science that is behind it. So we know science has proven that a person's sense of well-being is directly connected to their overall physical health. So these are just some of the things that we're talking about. We work a lot with this in the workplace, and I know our next presenter will be probably sharing a lot more about mental wellness and how people can address that as well. All right. So of the top priorities that American Heart Association is, the top priorities, that 3 areas that we identified for New Mexico, or that was identified through community needs health assessment, or community health needs assessment, was hypertension, nutrition security, and tobacco, and this is recreational or commercial tobacco and vaping. So these came out of both looking at many of our hospital systems community health needs assessment, doing our own community health needs assessment, working with the CDPC on that, and then recently doing an update on it. So the process that we went through is basically pulling a lot of that information that was already out there, addressing that, and then looking at and identifying some of the policy programs and community interventions. So right now we're looking at phase 2 in this, with the work and the stroke and heart disease work group, and looking at really what are some actionable steps that we could take in the next phase. So we're reducing blood pressure and chronic disease. This was something that really came up that was really important in the work that we're doing. Some things that are really specific to the time of COVID-19 is that unfortunately, the data is showing that when we are going to come out of COVID-19 in a less healthy situation. People are coming getting to their doctors, that they're more acute, they're sicker. So what we've done some campaigns about really trying to help people continue on with their care. Definitely a lot of people during COVID-19 were not going out and seeking care during that time. So one of the initiatives that American Heart Association has done is really look at different ways that we can help the community do that. Really one of the strongest initiatives that we have right now is self-monitoring blood pressure. So it's about educating the community and working with our partners to set up training, education, best practices on that, providing resources and tools out into the community for self-monitoring blood pressure. One of those kind of key areas that, also being a rural state, that we have to look at is that during COVID, telemedicine has really came forward as a way of addressing that. But here in our state, again, we have to look at our rural communities and seeing some of the, I don't know if you want to call it structural racism, but some of the foundations that aren't there in some of our communities to be able to support. Like they don't have broadband, internet access. So there are still some, even though there's been some creations of some possibilities to overcome some of the situations that were created, some of our communities here in New Mexico don't have access to that because of some of the technology challenges of our state. So those are some things that we want to look at when we're looking at self-monitoring blood pressure of our telemedicine. What are some ways that we can help address that? The number one, the thing that popped up was definitely during COVID-19 was nutrition security. And we at American Heart Association really take a broader, big look at nutrition security. So it's not just a matter of having access to food, it's accessing food. So it's nutritional food. It's not just about calorie intake, it has to be nutritious. And then also, if you really want to address it, it has to be sustained. So what are some ways that we could address nutrition insecurity in a sustainable way? How can we educate people on that? From the story that you heard about with Michelle's story, you know, much of our state is in a, you know, considered food deserts. So what does that look like, and how can we address that? And how it looks on, you know, in a native community may look different in a farming community or a mining or, you know, agricultural community. So those are different things that we have to look at each one about how we're going to address that. But then it's also educating people on what is nutritional value and what is, you know, and how to eat healthily. That's not the word. So, but it's educating people on it as well, and providing them with the resources to be their own advocates when it comes to nutrition security. Some of the work that we're doing right now is that we are looking at clean water access. Those are really important, especially in schools. We're working with schools right now addressing that. And then also addressing right now what is happening in our restaurants as far as keeping up nutritional standards. Yep. Let's see. Ending tobacco use and vaping. This is an important one that we're working on. We're working with a lot of this at the district level. So what we want is we want tobacco-free schools to be a part of AHA's education system. And what this means is that, and we want to do it in a thoughtful manner, that we appreciate when school districts go and do zero tolerance. But what we find is that we don't want to create other problems for our kids, our communities, with what we're doing to kind of shape how we're addressing tobacco use or vaping in the school districts. So what we want to do is really work in what we call a more supportive way of going about it instead of a punitive way. We really want schools, when they're addressing tobacco use in their schools, is to have to be more about helping students quit rather than suspension or things that negatively impact the students already. So we are really working on schools to understand and to help kind of create that and provide them with the resources and goals of what a tobacco-free school really looks like. So that is a little bit about that. It's always about education and providing resources on cessation and moving forward with that. So that is kind of ran a little short because of the video, but really, those are the top three that we're looking at the American Heart Association is tobacco free or tobacco use and vaping, hypertension, and nutrition security. All of those areas that are in part of that peacock are something that we work at, but those are really our top three priorities that have come out of the community needs health assessment. So I was not able to, I saw a couple of the things in there. Are there any questions? I know I kind of gave a lot of information, and yes, the PowerPoint will be up on the website, so you can kind of go back and look into that. But do you have any questions at this point? Thanks. Thank you.
Sheryl, I just wanted to
Right.
ask you to elaborate on the non-punitive approach that you're taking with the schools for tobacco prevention. If you
Oh,
could.
sure. Absolutely. So what we want to do is we want to work with, what we do is the first thing that we do is go in and we look at the code of conduct for a district and their policies. So what we want to do is be more progressive. Instead of having a zero tolerance saying if you're caught vaping or using tobacco on the school campus, you're going to be suspended or you're going to, or you're going to get detention. We want the student in the class where they can learn. A good example of it is like if a kid is not understanding math, you don't suspend them, you help them. So if a kid is having, understanding tobacco use, sometimes it's a way of dealing with stress, it's, different things. So what we want to do is work with the school districts to create a policy and a roadmap of that, that first of all, so they change their policy, they change their way of being, they change their code of conduct. That is, okay, the first time, and also we would love schools to not implement their resource officers on the first go around. Often that is being sent over to the resource center and the resource officers. So instead have with a school counselor or an identified staff person that can work with the school or can work with the students to find out, does the student want to quit? And then connect the students with resources. Of course, we know, that then there's the second offense or the third offense and the fourth. So we wanted to be a little more progressive and really focusing on helping the student quit and educating them and raising their awareness of what it is that they're doing and ways that we can help them quit versus being, punishing them for that.
Thank you, Sheryl. Thanks, that's helpful. Emma Green has her hand up. Emma, did you want to ask a question or comment?
The mute unmute still gets me. Yeah, thanks. I just wanted to comment on that. Thank you. I come from a world of restorative justice and restorative practices, and what you're speaking to right there is that we're really acting in a restorative way. And so I guess I just wanted to encourage anyone else that's on the call to really, think about what you said, Sheryl, and kind of gather around that kiddo and see what's going on, and maybe even have, a restorative conversation with a doctor and a parent or a guardian and, just different people who are impacted by that. I highly support that. Thank you.
Thanks, Emma. There was Jimmy, you also had a comment you wanted to add to that, and I'll get to a question that's in the chat there as well. Go ahead, Jimmy, if you want to unmute and share.
Sure. In addition, I just put some information in the chat regarding the Attendance for Success Act that pretty much frowns upon expulsion or suspension for almost anything except the most very extreme cases. In order to increase student attendance, you want to have them actively involved and be more proactive about what used to be zero tolerance policies regarding vaping or many other infractions. And the idea is to keep the kids at school and work with them in, like Emma said, in a restorative justice kind of a setting. So,
yeah, thanks for adding that in. We know that with the, as you mentioned, with institutional racism and how those zero tolerance policies have contributed to that school to prison pipeline, where people of color tend to be disproportionately impacted by those discipline policies in the school. And this being one where that can be addressed is really helpful to know about, and that Attendance for Success that we'll have to look at. Is that something that, Jimmy, we could find somewhere, or is that something that we have a link for? If you have anything like that, feel free to share that. That'd be great.
I will do that right now.
Good.